Welcome to the last in a series of presentations on the topic of disorders predominantly affecting the diaphysis, metaphysis, and physis in veterinary patients. The intent of this presentation is to provide case-based practice to help you identify abnormalities of the musculoskeletal system and to be able to apply the knowledge that you have gained to determine appropriate differentials for a given patient presentation. So let's start with this first case. This is a 3-year-old neutered male Labrador who is presenting with swelling and pain. Just to help you, remember I use a 4-step approach, and my first step is to make sure that I like the study that I have. We are centered and collimated on the tarsus. Positioning is pretty good, a little bit rotated on the DP view, but we have good exposure, and we also can tell that we have an skeletally mature dog. Now, my next step was really finding the obvious or the holy cow finding, but I'm going to skip that for now, and I'm going to go into my third step, which is looking at the study systematically. And one system I had told you you could use is to start with just overall alignment of the structures, and this looks like it's well aligned. I don't see any obvious fractures or any disarticulations. Then I like to look at the soft tissues. And as I'm assessing the soft tissues around the tarsus and metatarsus, I do see soft tissue swelling is predominantly at the plantar aspect. It seems predominantly associated with the calcaneus here. I do see some medially and laterally. So this is really extracapsular soft tissue swelling. So remember, it's not centered on a joint, but it's rather centered on a non-joint structure. Then after that, I like to look at the osseous structure starting from proximal to distal. And I had talked about looking at the cortex, both the periosteal and the endosteal surface, looking at the medullary region, looking at the periarticular areas, as well as the subchondral and articular cartilage regions, and then just continuing on down. I really am seeing my predominant abnormality affecting the calcaneus here. In the calcaneus, pretty much diffusely, I see probably a combination of permeative and moth-eaten lysis, and notice that the lysis, especially the permeative, is affecting the cortices. Best seen on this lateral view. The remainder of the bones are all normal. This trabecular pattern, the lucency in the center of the tarsal bones, that's all normal. So really my only abnormality is of the calcaneus. And if I look beyond the lysis, I believe that there is a spiculated type of periosteal reaction on the caudal cortex as well. And then I also see these separate osseous fragments that are distal to the calcaneus as well as medial to the talus and the calcaneus on the DP view. And then my final finding is that I am missing a portion of calcaneus here, and that is because the piece here associated with the talus is separated from the remainder of the calcaneus, and so this is a fracture. Because the bone underlying it is abnormal, this is a pathologic fracture. That's probably also why we have these little fragments here, is that they are other portions of a fracture. So looking at this lesion of the calcaneus, it has aggressive changes. So aggressiveness based on the pattern of lysis, which is permeative and moth-eaten, as well as the fact that the cortex is involved, and then also on the fact that I believe that this is a spiculated periosteal reaction. So all of those things tell me that this is an aggressive lesion, and then it has associated soft tissue swelling. So looking at this patient, it is a relatively young dog with an aggressive lesion affecting the calcaneus. And I think that really high on our list, we have to consider fungal osteomyelitis. I think it would be less likely that this would be a soft tissue tumor with this extensive lysis involving the calcaneus. And although primary bone tumors can affect the tarsal and carpal bones, those are less common, and this is not really the correct age of the patient either. So it's not really that young age, and it's not really that old age. So I think a primary bone tumor would be unlikely as well. So my prioritized differential list would be fungal osteomyelitis, maybe followed by soft tissue neoplasm or a primary bone tumor. And this patient was diagnosed with fungal osteomyelitis from blastomycosis infection, which was diagnosed by a fine needle aspirate of the soft tissue and bony changes. Our next case is a 9-year-old spayed female golden retriever who's presenting for a swollen left front limb with limping. So we have not really centered well on the carpus. We've included quite a bit of the anabrachium. So we're not really on a certain area, but other than that, our craniocaudal or DP view and our lateral view are at least well positioned. They're nice and straight. The exposure is good as well for both the soft tissue and the osseous structures. So now when I look at this patient, I think we'll start with this craniocaudal view. I'm noticing that there is this irregular and extensive soft tissue swelling. And again, like I said, it's pretty irregular, that's involving the distal anabrachium down in through the carpus, and then it's more focally mass-like, kind of dorsal to the distal radius and carpus. So since this is so extensive, at least the majority of this has to be extracapsular, irregular, soft tissue enlargement. So now looking at the bones, let's start with the radius. There is this kind of solid, slightly irregular periosteal reaction on the medial cortex with a more kind of exostosis or extra periosteal proliferation down here distally. In this area, I also see kind of what looks like a geographic to moth-eaten region of lysis. In the more lateral part of the radius, it also looks like there is some potential lysis as well. And then when we look at this ulna, the ulna also has a kind of solid periosteal reaction, but along this kind of medial aspect, we can see this kind of geographic but irregular lysis. Some of the periosteal reaction and the lysis is identified on the lateral view as well. And then it's hard to tell, but there may actually be some geographic lysis in some of these carpal bones at the dorsal aspect. So when I look at this patient, this is a polyostotic lesion, so it's involving the radius, the ulna, and potentially some carpal bones. Relatively benign to semi-aggressive periosteal reaction. Also, relatively like non-aggressive geographic lysis, although some of it might be a little bit moth-eaten. So the fact that we have this irregular soft tissue swelling, as well as at least 2, if not more, bones involved, my differentials have to include something like a soft tissue tumor, so like a soft tissue sarcoma. And I think it would be highly unlikely that this would be something infectious, either bacterial or fungal. And certainly we cannot have a primary bone tumor on our differential list because there are at least 2 bones, if not another couple bones involved. So primary bone tumor should not be on our list. So really, my primary differential is going to be a soft tissue neoplasm causing this kind of irregular and mass-like swelling with secondary effects on the bone. And this indeed is a soft tissue sarcoma. Our next case is a 6-month-old male Labrador mix. We have orthogonal views of the bilateral anabrachii. I first noticed that yes, this is indeed a young dog. So we have open growth plates here. We have good positioning and exposure. Remember, for long bones, we want to have a joint above and the joint below. So we have that bilaterally here. So pain and lameness for a few days in a relatively young patient. So in this patient, alignment looks good. And then I again look for soft tissues. And when I look down by this distal ulna, I do see this kind of focal soft tissue swelling that's extracapsular on the right side, kind of centered around the distal ulnar metaphysis. And when I look at the left side, I also see similar soft tissue swelling that is extracapsular centered at the distal ulnar metaphysis. The other soft tissues are fairly normal. Then looking at the bone as I go proximally coming down through the joints and continuing on through the radius and the ulna, all of the bony structures so far look okay on both sides. But when I get down towards the distal radius and ulna, especially in the distal ulna, I'm noticing these transversely oriented radiolucent zones in the distal metaphysis. You can see them well on both lateral and craniocaudal view, and I probably see it even more significantly in the distal left ulnar metaphysis. Both of these have a little bit of metaphyseal sclerosis adjacent to them. And then if I keep looking, when I look at the radius, especially on the craniocaudal view, there might be a small faint zone of those transversely oriented radiolucencies that are adjacent and parallel to the physis. The rest of the bones look okay. So in this patient, this age, and in this location with this appearance, really my primary differential is going to be that hypertrophic osteodystrophy, or HOD. Remember that we said there was a possibility that hematogenous bacterial infection could spread like this, but this is really classic for HOD, and this is the right patient, right signement. So that would be my primary differential. All right, let's look at the next case. This is a 1-month-old Arabian colt who has pain and lameness that is localized to the right front fetlock. And so we have orthogonal views, lateral and a DP. Typically of the fetlock, we would have 2 oblique views. So right away I notice that I don't have a complete study. It is centered and collimated, but I also notice that this is not the greatest exposure for both bones and soft tissues. And just for an aside, the reason that is that these are actually film-based radiographs that were digitized, and so we're going to lose some of that latitude. They're not as lovely as our digital images that we obtain in most practices these days. So looking at this is a young patient, because this is the third metacarpal bone. It has an open physis. The proximal phalanx also has an open physis, so that fits. It looks like a horse, so that fits as well. Now it's going to be challenging. So looking at it, no alignment issues, but it's going to be challenging to look at the soft tissues on this study. However, I am going to point out that there is some soft tissue swelling that is predominantly extracapsular centered at the level of the physis in this patient. When I look at the osseous structures, everything is pretty normal with the exception of this focal area of geographic lysis, and it is in both the metaphysis as well as extending into the epiphysis, fairly centered on that distal physis there. When we look on the orthogonal view, I can see that it is very focal at the lateral aspect of this bone, again centered on the physis with lysis in the metaphysis and the epiphysis. As I look more closely, I see one other abnormality that's important. On the lateral view, when I look at the area of lysis in the distal metaphysis, I see this very linear, sharply marginated, and very opaque piece of bone. So when I look at all of these things in combination, my conclusion is that this focal area of lysis centered on the physis is very consistent with a region of hematogenous spread of bacterial osteomyelitis, and this very opaque linear piece of bone here is very consistent with a sequestrum. So this patient has bacterial osteomyelitis with sequestrum formation. And in this case, it was hematogenous spread, and it was spread to the physis where that rich capillary bed is. Now, I want to make a distinction between this being an infection and the physeal dysplasia we learned about. Remember, the physeal dysplasia did cause some widening and irregularity to the physis, but it did not cause lysis in the surrounding bone. So the lysis in the metaphysis and the epiphysis should lead us away from physeal dysplasia. All right, case 5 is a 6-year-old spayed female Great Dane who's been limping for the past couple weeks, and the limping is worsening. We have orthogonal views of the antebrachium, and they are nicely made, good positioning. We have collimated to the antebrachium, but we have included the joint above and the joint below. The exposure is nice for the soft tissues and the bones. When I look at this patient, I don't see any alignment issues. When I next look at soft tissues, I see focal soft tissue swelling that is at the cranial aspect of the distal radius. It also looks like it goes a little bit medially. I don't see any other soft tissue changes, so this is focal extracapsular, almost mass-like soft tissue swelling. When I look at the bone starting proximally and moving distally, really the only abnormality I see is in this distal radius, and centered at the metaphysis with involvement of the distal diaphysis and the epiphysis is a region of very severe moth-eaten lysis with very severe involved cortical lysis as well. This seems to kind of expand the bone. Notice that the bone looks a little bit wider. There is a little bit of probably spiculated periosteal reaction, maybe even a little bit of amorphous periosteal reaction. And this lesion is only involving the distal radius. Notice the lesion also is indistinctly marginated, so it has a poor transition zone. The ulna is not involved, and you do have to carefully look at the ulna to make sure that anything you think you see is not superimposition from the expansion of the radial lesion. In the ulna, there is one little abnormality, and it is this perpendicularly projected, kind of smoothly marginated, I'm going to call it an exostosis, which is just like a lump of bone that is in the distal metaphysis. And we're going to come back to that. It has nothing to do with this other lesion. So this lesion in the distal radius is quite aggressive looking. So we've got that moth-eaten lysis, we have periosteal amorphous proliferation, and we have a poor transition zone with additional cortical lysis. So we have an aggressive monostotic, so one bone involved lesion of the distal radius. And in this middle-aged to older Great Dane, this would be very consistent with what a primary bone tumor would look like. So my primary differential is going to be a primary bone tumor of this distal radius. It's a perfect spot. It's the perfect large giant breed dog and the perfect age. Now, because we can't be specific, it is possible still that this could be a metastatic lesion. I would say that probably fungal osteomyelitis or a soft tissue tumor are less likely. Now, this lesion over here in the ulna, this is a very benign lesion, very non-aggressive lesion. It has a very distinct transition zone. It is a very smoothly marginated piece of bone. And this is actually a benign bone tumor called an osteochondroma. Now let's look at this patient. This is an 8-month-old neutered male domestic shorthair cat who's presenting with a painful and swollen limb and is limping. We have a set of radiographs, orthogonal views of the antebrachium. They are pretty well positioned, a little bit rotated on the craniocaudal view. They are fairly collimated to the anabrachium, and they include the joint above and below, and they have good exposure for soft tissues and bones. When I start looking at this, I can actually see that it is a cat. I do believe there's still open physes, so that would fit with the age, being 8-month-old. I don't see any poor alignment here, but I do see very extensive soft tissue swelling, fairly irregular, very severe down here in the distal anabrachium, kind of centered at the level of the distal radial and ulnar metaphyses. So this is all extracapsular soft tissue swelling. Looking at the osseous structures, we start to see quite a bit of abnormality when we get into the distal diaphysis of the radius and the ulna, and then moving down into the metaphyses toward the physes. This patient has very severe lysis. Some of it is moth-eaten, some of it is permeative, some of it is just completely gone, so you can't even give it a pattern. So severe lysis involving the radius and the ulna. And then these bones also have some periosteal reaction. So here I see some solid and some irregular periosteal reaction that's on both the radius and the ulna. One thing I forgot to point out is that there is cortical lysis on both the radius and the ulna as well. So this is actually a fairly aggressive looking lesion because it has that moth-eaten and permeative lysis. The transition zone is actually pretty indistinct as we go from normal to more and more abnormal bone. The periosteal reaction itself, though, is a kind of non-aggressive reaction. So in this age patient, at 8-month-old, with this degree of osseous change, we have to consider probably some sort of infection involving more than one bone. This could be a very severe bacterial infection, especially if the patient was compromised in some way. But this is such an aggressive lesion, we should consider fungal osteomyelitis as well. And in this patient, this was actually a histoplasmosis fungal osteomyelitis. And we would have to determine that by sampling and then maybe culturing and doing a sensitivity as well in case it was fungal or a bacterial infection. This case is a 2-year-old spayed female golden doodle, and this patient has had several days to weeks of thoracic limb lameness. It was localized to the proximal limb, so we have orthogonal views of the shoulder. When I look at this patient, we have, centered and collimated pretty well to the shoulder, and we have good exposure. I can see that it is a dog, and it does look like it's skeletally mature. I don't see any malalignments or fractures or anything like that. I do see quite a bit of soft tissue swelling. This is a lot more soft tissue than we would normally see in the proximal humerus, so quite a bit of soft tissue swelling. And then when I'm looking at the osseous structures, the scapula, that looks okay, but when I get down into the humerus, then I can start to see what looks to be predominantly proliferative. It looks like there is some palisading and maybe some spiculated periosteal reaction on the kind of cranial and caudal cortices, as well as on the medial and lateral cortices. Seems to be predominantly centered at the proximal metaphysis. I do believe that there is a little bit of subtle moth-eaten lysis also within this predominantly proliferative lesion. Very distally, we can actually see a solid periosteal reaction, but we can also see that the transition zone from normal to abnormal is indistinct, so a long transition zone, maybe even some of this is some lysis down here. So we have a aggressive looking lesion, and the aggressiveness is based upon the moth-eaten lysis as well as the portions of spiculated periosteal reaction in combination with the indistinct zone of transition. So in a patient that is 2 years old, I think we need to consider the possibility of fungal osteomyelitis, But also, don't forget that we could have a juvenile onset osteosarcoma or primary bone tumor in this age of a patient. And this indeed was biopsied and is a juvenile onset osteosarcoma. All right, this is our last case. This is a 2-year-old neutered male German Shepherd dog who presented painful around the elbow after running outside. So we have orthogonal views that are centered and collimated to the elbow, and they are of good quality. I can see that it is a dog and it is skeletally mature, so we have the right patient here. I think our findings will show up best on the lateral view. When I look at this patient, I don't see any malalignment, so I might be thinking about fractures or joint luxations because he was running around outside and could have traumatized himself. I don't see any soft tissue swelling. Everything I see looks like it has normal fascial planes. So let's start looking at the bones from proximal to distal. And when I look at this humerus, I notice that there is mottled change in the medullary cavity of the humerus. And the change is that there are regions of increased bone opacity or medullary sclerosis. It's causing some poor distinction between the endosteal surface of the cortex and the medullary canal. So I see that. As I continue on, the joint looks okay, but when I start looking at the radius and the ulna, I notice that the ulna proximally here and the proximal diaphysis also has kind of this diffuse and almost nodular increased bone opacity or medullary sclerosis. And then in the radius, I also see 1 and 2 kind of circumscribed nodular areas of medullary sclerosis. Again, all of these show up best on the lateral view. I can see the humerus a little bit on the craniocaudal view. So these findings are pretty pathognomonic for panosteitis. And this patient is a little bit older than we typically think about it in. However, it still is classic for panosteitis, and German Shepherd dogs were one of the breeds that are really known to get this. And so that is going to be really the only differential that I have for this dog, and I don't see any signs of trauma. So be sure to consult references for additional examples. Peruse the appropriate chapters of the textbooks listed here. And I would recommend that you just consider viewing the figures. You can look at the radiographs that they have, and you can make your own assessment prior to reading the legend. So that will give you some additional practice. And then I want to remind you that on your course Canvas site, in the general information section, is a link to this website that is Veterinary Radiology. And if you link on that, you will see, this is just a portion of what the web page looks like, but you will see this web page, and when you start kind of playing around with it, you can choose a modality. You could choose radiographs, ultrasound, I think MRI or CT, or you can choose a region, and in this instance, I have actually chosen the musculoskeletal system, or you could choose a species. So you could choose, dog or horse. Unfortunately, you can't choose out of each of these. You have to decide what you want to do. So for our purposes, you might want to choose musculoskeletal. And then when you go to this area, if you scroll down under musculoskeletal, she will have many cases posted that are going to be similar to our course lab cases. You'll be able to view the images. You can make them larger. You can see some general information that would include the signement and the kind of history that's pertinent. And then once you view the images and make your own list of findings and conclusions, you can access the tabs that have her findings and her conclusions for the study. So that should be able to give you some more practice, because remember that it really is practice that you need to help you feel comfortable identifying the abnormalities and coming to good conclusions.